Hi, everybody. Welcome back to RetFix and Chill. We're here today with my good friend Greg Lee, who's here from Georgia Retina, and we're going to be talking about some tips and tricks that he finds really useful, especially when doing complex surgery. So, Greg, I was doing this case recently of persistent MAC hole, small hole, like 400 microns. Didn't work with the initial ILM peel, so I did a wider ILM peel. And then I'm going in there. I go use the 39 gauge Med 1 cannula. I go in injecting at like 12 to 16 psi on the 10 cc oil syringe with BSS. And I've just struggled every time I do it. It's sort of not very elegant. I know you have some great tips and some alternatives that you've used in these cases, and I'd love to hear about them.
Yeah, so I think fortunately and unfortunately, I ended up having a good number of these cases. And by good number, I mean like 3 or 4 cases in a row in my first year at Georgia Retina. And you look back at your fellowship and all your numbers and you say, was I doing something different here? Why did these not close and then the other ones closed in my past history? So then you're trying to figure out, like, is there a different technique or something else going on with what I'm doing, or is this just the law of randomness, and that when complications happen or bad results happen, they usually come in clusters.
Is it me or is it the patient, right?
Absolutely. So I look back and I reviewed some of the videos that I did, and then ultimately, I've been doing similar technique as what I was doing beforehand, and I've been having just as good results afterwards. So I think that's the first thing I'll say is especially when you're starting out, you can really get a lot of doubts with a couple bad outcomes or a couple unexpected bad outcomes. And then you start doing all these extra maneuvers that may or may not be necessary. And so I think that's like a big tip that I've felt was really helpful, getting that advice from like mentors of mine about just sort of keep doing you. And then obviously if it's still not working, then you have to adjust your things that you're doing. So in terms of dealing with these, first thing is, the first couple of cases that I did, I ended up having to reoperate on them, doing C3F8, doing a free flap, and then they still didn't close. And then the third surgery, by this time, the patient's starting to have a little bit of creeping doubts, especially if you look young, that they're like,
you still do.
Thank you very much. But yeah, they're going to start saying like, can I get a second opinion? And I've never had a problem with sending a patient for a second opinion within our group or outside of our group, because I feel like the things that we're doing are pretty solid. So I'm like, please go see someone else if you feel that's necessary. And then if you still want to do surgery, there are a couple maneuvers we can do, but it's a little bit on the time sensitive side. You don't want to wait for these holes to be there for 3 months before you get back to them. So ideally you want to get to these within the first 2 to 4 weeks of that original surgery. The tips that I've learned are really using fluid as a stretching device. So instead, and you've seen various techniques of this. People use visco, people use manual sort of things to give more flexibility to the retina to get it to close at the hole. But to me, the fluid seemed the best version of events and the least sort of manipulative and invasive on the retina. I never wanted to sort of like brush or scrape the retina to just get that flexibility. So I thought that the fluid was sort of the enough and not extra sort of thing. And I think when you're doing the injection, we didn't necessarily have the handpiece that connected for the 10 cc syringe and the 39 gauge cannula. So then I was like, well, what do we have that otherwise works just as well? And the soft tip came to mind. It's already in the pack. And then for me, I have my settings so that you can use a proportional reflux. And so I was like, that's the same as having essentially like, it's kind of poor man's version of a VFC cannula. And as long as you have clean fluid in there, obviously if you suck up a bunch of dirty fluid from the eye and then you're trying to re-inject that subretinal, you could cause some issues there. So that's kind of like my technique. And then the soft tip, you just sit down gently right on the retina, and you don't have to actually press into the retina at all. With the fluid wave that you get and the amount of fluid that's shooting out of this thing, if you've ever accidentally shot ICG or something else into like a subretinal space, you just have to get the right jet of fluid in the right sort of direction. So you want to be kind of 90 degrees. And this illustration is sort of a really great sort of idea of kind of what you actually have to do. So you want the whole opening of the soft tip to be sitting onto the retina so that fluid's not just sort of shooting along the surface, and then 90 degrees there. And then you just increase your proportional reflux or your VFC for that instance until you get a fluid wave. And it's generally somewhere around 20 to 40 millimeters mercury that you're getting that sort of little fluid that opens up. I got to give credit to my wife here. She's a graphic designer, and so she was the one who made this illustration.
It looks fantastic. So, and this is assuming you've peeled, correct?
Yeah, this is an area that you've already peeled ILM.
Got it. So this you could also actually technically use this on the VFC as well. Using like a fresh, 10 cc syringe, obviously adjusting, the PSI, because, the settings that we use are for the 3039. Do you have a case? You want
Yeah.
to talk just a little bit through this case?
So this is like a case. This is one of those cases, unfortunately, that I was talking about, that it looked really straightforward from the very beginning.
It looks like a small hole.
Yeah, it's small hole. It was like a medium hole, I think, based on measurements. It was maybe like 250, 300 microns.
Yeah.
It has VMT. It seems like all the things should be working in our favor to be able to close this hole.
Yeah.
Unfortunately, it did not. And so 1 week post-op, we get a scan through the retina, and you can see that the hole is still open. So,
vibe is killed.
And she's like, why did I do all this face-down positioning?
Right.
Because, an 81-year-old woman, she's not super happy about this kind of result.
Yeah, it sucks. Also, especially because like in a case like this, I mean, you can see that you did a pretty wide ILM peel as well. There's like no ILM or ERM left here. So it's disappointing when it doesn't work. It suggests some chronicity.
Yeah. And so, some retinas just, they don't want to close. Sometimes the detachment doesn't want to close either. And so it's sort of one of these things where I don't necessarily dwell on this when I'm talking to patients preoperatively, but, I think every patient goes into a surgery thinking that they're going to be that 90 to 95 or 98% of whatever the statistic you want to give on hole closure or detachment success rate.
Sure.
And, no one likes to be that outlier. So this one, it does take a little bit of learning and art to sort of break this news to the patient in an honest way, and then also get them to be okay with you reoperating on them in a quick way.
Yeah, what you mentioned about, that when patients want to get another opinion, I also always encourage that as well. Sometimes, if I've operated on someone twice already, I actually offer them that. Not for me. It's more for the patient, just to be like, hey, look, I want you to know that you've gotten other opinions, simply to have another pair of eyes, take a look at the same pathology. And sometimes, the second opinion comes back. It's like, oh, let's try this other thing. And then it's an opportunity to learn and get better as well. So what did you end up doing here?
So this one, I ended up doing the technique I was talking about. And so we set her up for this soft tip reflux technique. So since we had harvested already the ILM all the way around with a wide peel, like you mentioned, I had to create a free flap. So I got a small little round free flap, and then I'm placing in the hole with the forceps there, and then just sort of tamping it down so it sort of sticks. And so I don't know, how that seems to work, but for whatever reason, whenever you sort of like tamp it down with the force, like a closed forcep in that area, it sort of like sticks to the edges of the hole a little bit. And then I haven't had the free flap sort of move as much on me. Obviously, sometimes they dislodge, but and this shows the settings of the constellation as the fluid is starting to go. And you see that little blush that occurs. That's when you've gotten fluid under there. And that's all I'm looking for. I'm trying to get that fluid to go up to the edge of the hole and not trying to do too much more. I think you can be more aggressive with that and do like fluid blebs in all 4 quadrants around the hole, and really
so you just did one here.
I did one supratemporally and one infratemporally. And so I try to avoid the PM bundle and things like that. So I feel like, and with this version of events, I've been able to get the holes to close, which to me means this is enough. And I think doing more is not always better. And that's sort of that real fine balance that you have to kind of walk with some of these cases, because you're always tempted to do more and more and more to try to get this to work. And to me, I was like, what's the bare minimum requirement? And I think this has been showing me that this is what we need to do.
Yeah, no, I mean, whenever I've tried to do it using 39 gauge needle, things happen a little bit slower, right? So I often have to do multiple touch sites. We've all seen those OCTs whenever we touch down on the retina. And even if you're gentle and injecting fluid, it's just not ideal, right? You can actually see those sites even during surgery, like the little white spots where you go in with a 39 gauge needle. Technically, it's a self-closing wound, but that is going through the RNFL.
Yeah. And, when I was doing it with 39 gauge needles, I was like, well, you can, when you do it for subretinal hemorrhage cases, you have to pierce the retina a little bit to get that fluid to start sort of going, because the amount of pressure that you can generate through that small of a needle is just not very high to spread through the retina to actually create a big enough bleb. And that's where the soft tip, because of its larger, bore diameter, that it's just going to give you a much more aggressive fluid jet, as long as you can kind of control it with either VFC or proportional reflex.
Sure. Awesome. And it looks like this patient had a really nice outcome. This is great.
Yeah, as much as I love to see these cases do well and the vision acuity do well, I do have to tell you, these patients, even if they get better vision, they are still going to have a little distortion when all said and done. And they're not always they're not as excited about the 20/70 vision as much as like we might be. And so that's where, they're happy that their hole is closed and that they have, some vision in the eye. But realistically, a lot of coaching goes into this as well, in the preoperative side of saying like we can get some improvement, but realistically, you will probably still have some distortion afterwards.
Especially, I mean, like the improvement in these patients, you can see the gradual improvement in the ellipsoid zone. I mean, it's just like sometimes patients have improvement that's like 1 to 2 years after that, which I think is like an important, there's a lot of chair time that goes into this as well. And you have another case. This looks like a more severe and chronic hole.
Big hole, yeah. And so 2-year chronic hole. Some of these, some people will argue, what's the point in doing these cases, right? Like these cases are generally not going to get much worse than they already are. And are you going to really get them any useful vision back? And I'm always of the mind of, who am I to dictate what a patient necessarily like wants to do, as long as it's like reasonable. If I'm like, if this patient was like trying to have their 4th or 5th surgery, I would say, like this is probably not worth it. But I think if they're like, let's just give it a try. Let's do this. And it's a little bit of a Hail Mary, but we'll do it. We'll give it one really good go. And if it gets you anything back, great. If it doesn't, then you're back where you started. And, like I think that the risks are small enough that we can sort of manage those things.
Yeah. So what did you end up doing here?
So this
surgery one.
Yeah, so surgery 1, I went straight to MAC hole and or straight to subretinal injections using the soft tip. And with this one, there's fresh ILM there, so you can do this hinged flap. And watching that, you can see the temporal edge sort of come in really far, and you could say maybe that was enough. Maybe a hinged flap would have been enough. But this is one where I had talked to the patient. I said, we're going to do one surgery, and I want to give you the best sort of chance with that one surgery to get this closure, and then just see where you end up. And so to me, that meant, just based on the size of it being 800 microns, I'm like, well, I think the flap closure can get us somewhere around 400 or 500 and lower, but 800, I feel like doing just a flap technique doesn't stretch the retina enough to close that hole.
Yeah, and like especially when it's chronic, it's just removing those adhesions to allow the retina to relax.
And to me, it's really that, it's like disrupting that adhesion that retina has formed at the edge of the hole. And that's why I want the fluid to go up to the edge of the hole, even if it reflexes out a little bit, and then just loosen up that retina there so it sort of displaces. And, the work that Mooney's done, like Rajiv's done great work in terms of retinal displacement stuff. We're kind of purposely displacing the retina here. So
don't tell Rajiv.
Yeah, I know.
There might be some low integrity retinal attachment, you know what I mean?
There's definitely going to be some lyra here.
This is closed. First times 1, and like they're still count fingers, but a lot of times these patients tell you, it's like, oh, I feel like I can see a little bit better, like the scotoma is better. There have been studies showing that the scotoma can improve. Yeah,
and they're getting like a little bit of signal like at the edge of the hole that they weren't having before. So they're getting a little bit better overlap in their binocular vision.
These things are hard to measure, right? But a patient will tell you, like, I feel like something is improved.
Yeah, I mean, this is like the same story of like GA, like visual acuity is such a poor measurement of like functionality in GA. And so, and especially when you have subfoveal disease. So in this sense, I'm just trying to get as much ellipsoid recovery as we can and, outer retinal recovery in that whole area.
It's nice even here from months 1 to 3, you can see the improvement in the ellipsoid zone. I think that's really cool. These are some additional.
We had like a series. Unfortunately, like I said, we had a series of these, and one of the other partners at Georgia Retina, Yogan Patel, started doing this technique because we were operating on the same day, and he unfortunately also had a couple like very reoperative holes, and then also some new super large holes. And so we started doing it, and we had I think like 12 cases or 15 cases, something like that. And so these are sort of examples of kind of like the good ones, obviously, but that shows that there is some potential possible for reops and then for the large holes in the next slide.
Yeah, I think, I mean, this is really great. I mean, the crazy thing is like, this happens to all of us, right? We all have these cases that are like, this is going to be a grand slam, limited ILM. Because back in the day, all we used to do is a vitrectomy, right? We didn't even do ILM peel unless it was VRM. But like, that came later. Like that data came much later. So that's, so when we do a limited ILM peel, it doesn't work. It kind of kills the vibe, But like every eye is different.
And to me, I'm looking for like, what is something that's basically like ILM flap plus instead of like ILM, you could say some of these large holes would probably close with the ILM flap, but I'm like, I kind of wanted the confidence that maybe I'm doing a little bit extra, but not like a whole lot extra, like not scraping, not pulling, not, cutting the retina that some people do these radial cuts and everything like that. And then but short of doing amniotic membrane and short of doing the autograft, because those I think have a place for very, very large holes and for real chronic
Traumatic
sort of,
holes.
more than like 1,000 microns. I think those have a very good place. But for me, I'm like looking for something in that between 5 to 900 range that gives me a little bit extra.
Have you incorporated this sort of like standard, or just when you feel like it's chronic?
When I see that it's chronic and that it has like the blunted edges and the patient has a history, they're telling me like it's been a year since they were able to see well enough to read.
Right.
Those are kind of the cues that I'm using. And then, as you're peeling, when you're sort of seeing how the retina reacts to how you peel, if you peel and the flap sort of brings it close and you're like, I think this can close, and that's sort of a judgment call. But if it's not, and you see the retina sort of like pretty stuck down and not super flexible, then to me, I'm like, okay, I have the soft tip available. It's already primed with fluid. Let's just sort of throw in a little couple
it's
blends.
No new instruments, and if you're just using the reflux, then you don't need to open an oil pack or anything like that. And you can use this technique in a lot of other cases, right?
Yeah. And so this is unfortunately, this is one of those other ones. Like you do your surgery really well, and then a patient positions really well, and then they're super miserable just because their retina has folded. And this is one of those things that you don't really think happens, but it does happen. And with the Lyra stuff that we mentioned before, it's like this is happening on a microscopic level in a lot of patients, but then when it's coming in a big, more significant way, then what do you do with the fold? If you have, and this patient, this is the initial sort of drawing of him.
I saw next tech drawing here.
Yeah, and so he was 20/50, and then to have a fold go through the macula, it's a patient who probably had like just a sliver of fluid through the macula. And arguably, this could be a pneumatic that you could probably reduce your Lyra with Mooney's technique. But in a lot of places in the U.S., at least, you don't have a lot of places that are doing as many pneumatics, although it's starting to take off a lot more. If you have easy access to an OR the next day and the patient wants a higher success rate than the 75 or 70% that's in literature, vitrectomy is the way.
Okay. I agree. I mean, that's like a separate discussion. I mean, I think like even it's a pneumatic candidate, it's also a great like vitrectomy candidate, But so in this case, you did a straight bit with SF6 face down positioning. Do you put them face down right after?
So this was a case where and this is something where wherever you go practice, you want to also like sort of fit in a little bit to how the staff handles like their post-op instruction. So it's a little bit more uniform across everyone. And so for a while, our staff was doing, straight face down. They would do sit and tip in the PACU where they're sort of sitting up but leaning forward. And then, these patients would be face down. So he had done face down for a full week. And then unfortunately at month 1, once his bubble disappeared, you could see that his fold just runs right through the macula. He's got
infratemporal as well.
Torsional diplopia. And if he didn't have the torsional diplopia, I think it would be one that I would just sort of say, let's just wait on this and not do anything. But for him, he was just so bothered. So I said, okay, well, as hard as we try to reattach retinas, you gotta have to purposely detach your retina.
He's phakic, right?
And he's phakic. And so we're like, well, and you have to have that real conversation with them about like, sorry that we have this result, but realistically, like we got to do something about this if you want to try to resolve this thing.
Question: when you go in for a re-op, so whenever I, have a patient that needs like an ERM or a MAC hole after the initial surgery, I like doing 27 gauge for the second surgery. When you do 27, so in a case like this, if I'm going back in trying to do induced macular detachment, I would consider maybe doing 27 gauge with the soft tip or whatever technique you want to use. Is that something that's worked for you? Because that's something that I like to do, like doing 27 for the second surgery, assuming there's no massive scar or anything like that.
That's a really interesting idea. Like I haven't really explored that. We have 27 available, but I just haven't really thought of even doing that.
Yeah.
That's like a really cool idea.
Yeah, I'll give it a try next week and I'll let you know.
So when you're watching this case, this is unfortunately a case it's a case where the gift keeps on giving. So it was not only that it was
you went right into the fold.
I went right into the fold. And then unfortunately, fluid goes to where the easiest or least amount of resistance is, which in these cases is often to the periphery. So,
damn it.
You think that we look at patients and we're like, oh, like detaching the macula, it happens within a few hours or a few days. And it's
Dr. Mehta's here.
It's just something where we think about like retinas detach so easily sometimes. But when you're trying to do it on purpose, it's like so difficult to detach this.
This is a soft tip, right?
Yeah.
You're using
so I was doing originally with 39 gauge needle.
Yeah.
And going into the fold and then trying to get that to basically unfold and then go into the macula, which was my original plan. Didn't work. So then I had to create some peripheral sites. And then I wasn't getting enough fluid to go
It's
through.
all going peripherally.
So then I was like, okay, then attach the soft tip to this time I used the VFC, and I was like, attach the soft tip to the VFC and let's go. And then let's get a lot of fluid jet to try to really sweep through the macula.
Yeah.
And then it kept going to the periphery. And then this is where stuff starts going wrong. So if you don't remember, your infusion is still a sharp instrument.
Oh no.
Oh no.
And when the retina goes there and you have fluid egress and it going out, the influx, the infusion works like a soft tip or like a suction device to maintain IOP. And it sucked up the retina there, created a big break. And so then...
But the fold is gone.
The fold is gone because I worked to just... Because we kept pumping more fluid in, and then...
It's a big break too.
So it was a big break. And so, and it was infratemporal. Fortunately, it's kind of in the area where the fold was, so it sort of gave us a little bit more of an area loosening and detach the macula. But it was right when the macula was like just detaching that it hit the infusion at that point. And so I was like, oh, we're almost home.
Never a dull moment,
and then that happened. So I was like, oh man.
What did you end up doing for the tamponade here?
So I used PFO because there was a little bit of bleeding that I wanted to keep outside the subretinal space. And so I ended up doing PFO to flatten out the retina all the way. And then I used C3F8. And then in line with the gift that keeps giving, for whatever reason, and I had watched the tech dilute the gas, this guy had hyperexpansile gas. So post-op day 1, pressure was like 30s. And so I gave him post-op to use. And I was like, okay, see me like, early next week. Because I had seen him on like a Friday. And then he calls me like the next day. He's like nauseous and vomiting. And I happened to be on call that weekend. So I was like, come in, let me take a look at you. And then pressure's like 50. And he's using his drops. I'm like, okay, well, I'm looking at his eye. There's nothing I can...
It's 100% gas fill.
100% gas fill, posterior feathering. I'm like, there is nothing that could explain this other than a expansile gas.
Yeah. And
so I was like, okay, well then let's tap you. And so I tapped a little bit of gas to get his pressure down to like normal. I got him back down to like low teens. And I was like, just in case, I want you to come back tomorrow.
The same thing.
Same exact thing. 3 taps later.
Daily.
Daily. Finally back to a normal tensive eye. And then by this time, the lens is just, complete awful, like haze in the posterior capsule. And, so I was like getting views around this PSC cataract at this point to see that his retina is still attached. But yeah, this is like...
I'm sorry, man. That's so sad. It's so stressful.
But it's a complicated case that you're just trying to survive that next step and problem solve each sort of step of the way and trying to use your, and as much as like you can hope that you have good outcomes always, you also have to be sort of like able to handle these things and roll with it, and then also like be straight up with the patient. And it's like, listen, like, I don't know why this gas is this concentration or that it's maybe your eye is this or whatever, but without blaming him or gaslighting him to say like, oh, your eye is just a bad eye and whatever. I'm just like, you know what? We could have gotten a higher concentration of gas, and that's why we're dealing with this. So we're doing this, tap to remove the gas, and, that's my best plan to get you better.
Planning you were at C3F8? You were thinking you may have given him like 16-18%, or who knows?
No idea.
Oh,
I mean,
nice.
they who knows? They might have accidentally diluted 20% thinking it was SF6 or like used to SF6 or who knows what happened. To me, I was like, I always ask for 12% on my C3F8 gases. That's just my routine sort of normal amount.
Yeah.
And so it should be a...
Do you draw your own gas?
Now I ask for when they draw the gas, I ask for the 100% gas.
Okay.
And then I dilute it myself.
Yeah, it was also a pro tip for anybody that has this problem, because unfortunately this does happen. Don't tap the AC, because if you tap the AC, it's just you're not getting rid of anything.
Well, you probably had a pretty shallow chamber to begin with, right?
Posterior pressure and all that stuff. So, and then you also like don't want to like tap too quick to get choroidal. Like it's just like it's such a you're threading the needle here.
The other thing that I think is really important is like, that's why when you're seeing these patients post-op day 1, when you have them like look down and you see that gas meniscus, it's actually nice. Yeah, it means it's not 100% gas fill, but it's not that often you do 100% gas fill unless you're doing straight vitrectomy for like an inferior RD, which a lot of people do buccal vitrectomies or buccal only for some of these cases. And I think that's or like a chronic macula, but even then you don't need 100% gas fill.
Absolutely.
So I think that's really important to check that.
Can you go over the concept of that, an occluded infusion line And when you're introducing PFO, it actually wants to suck in, right?
Yeah, we have to remember that the Constellation, not just the Constellation, but any vitrectomy machine at this point in time is designed to maintain a level IOP, right? And that's
Right.
like its main goal with the infusion. And so that means that if you are putting in fluid or increasing pressure without a dual bore or without like a, if you're pressing the dual bore way too fast, that doesn't allow for egress of fluid through the dual bore, you are pressurizing the eye. And the only other exit is through your other port. And if you're using valves and your valves are pretty sealed, then it's really through your infusion. And your machine is designed to detect IOP and then do what it needs to do to maintain the pressure at whatever level you set it at.
So when the retina hit and occluded, basically
because you're putting in PFO at the same
yeah,
time.
it's
right?
like it's like taking a non-soft tipped, cannula and then just
shoving it through the retina.
sucking up retina
Right.
that's already detached.
Right, and I've also heard that the next generation is going to be able to suck up air as well versus just fluid, which might actually make silicone oil insertion easier. I think that's the goal of it. But it's important to remember that it will do this for fluid on the Constellation, but it won't do it for air.
Yeah, absolutely.
Yes, but hey, how did the patient end up doing?
I got some photos to show, despite all the loss of sleep and stress and loss of life of years, the patient ended up doing pretty good. And so the retina looks like a mess on the fundus photo, but thankfully,
Fold is gone.
Fold is gone. He's 20/60, no torsion. So, this is where I'm like, this is as good an outcome as I could have possibly hoped for this guy. And so, unfortunately, he also had a slightly botched cataract surgery because his zonules had been loosened up by all the pressure effects and multiple surgeries. And so he has like a slightly tilted lens that's like half in and half outside the capsule. Yeah. One of the arms is like in the sulcus, and I've been very, very loath to go into the side again to do anything about it. And so he developed CME, and we've been fighting it with STK, and thankfully he's actually doing really good. So I have his like final OCT here and an autofluorescence to sort of show.
Nice.
And you can see the lira here, and so you can see the ghosted vessels in the autofluorescence, and that's sort of what we were kind of purposely hoping for, but also not as severe as originally what he had. And then his OCT, the fovea actually restored pretty well.
Looks
so
great.
Yeah.
It looks great.
I agree, even though I missed the beginning. I was doing a pneumatic upstairs.
Well, with the pneumatic, you'll get less of this.
Hopefully, yeah.